Today we will talk about secondary hemostasis or coagulation in particular. But let's just first have a brief discussion of what hemostasis is. The term hemostasis means prevention of bleeding. And so it is the mechanism by which the body prevents blood loss. So previously we talked about primary hemostasis. You can find the video on my channel if you want to learn more about the primary hemostasis. But in this video, we'll just kind of superficially graze or touch the topic. So, so first, when there is an injury, when there is an injury to the vessel, then the first thing that happens is primary hemostasis, which ends in the formation of platelet plug. So the first thing that happens when the vessel is damaged during the primary hemostasis is transient vasoconstriction, and this is due to endothelin and nerve reflex, and then the subendothelial collagen or alveolar factor are exposed, and that result in platelet adhesion, and then the fibrinogen kind of links the platelets and result in platelet aggregation. So most of the small injuries will be resolved by primary hemostasis, and you do not need secondary hemostasis for that. The primary hemostasis is enough, and that will just resolve the small injuries. But when the injury to the vessel is large, then there is something called the secondary hemostasis, which involves the clotting factor of coagulation gets activated. The secondary hemostasis basically occurs by two mechanisms. First is the extrinsic pathway, and the other is the intrinsic pathway. So now, in order for the blood, so what determines whether the blood will clot or not? It actually depends on the balance between anticoagulants and procoagulants. So when there is trauma to the vessel, then the procoagulants, so if this is the procoagulant, the procoagulant levels increase. This is the procoagulant. The level of this is increased when the vessel is damaged, and the levels of procoagulants increases relative to anticoagulants, and that would result in clot formation. So first, let's talk about the extrinsic pathway. So how is it activated? So the extrinsic pathway is activated when there is trauma to extrinsic to the vessel, and then the vessel is also traumatized. So if this is the skin, and there is trauma from external, then the entire tissue will be affected, will be damaged, and this would result in exposure of the blood to the tissue factor, and the tissue factor or tissue thromboplastin, and this will then activate the extrinsic pathway. We'll talk about the factors that are involved in a bit in the extrinsic pathway. Then let's talk about the intrinsic pathway, which is a slower pathway because it involves more clotting factors. And so the intrinsic pathway kind of gets activated when there is trauma internally. So internal trauma to the blood would result in exposure to the subendothelium. Here, for example, is the subendothelium, and here there is a substance called subendothelial collagen. And when that is exposed to blood, when blood is exposed to subendothelial collagen due to internal trauma, that would activate the intrinsic pathway. And intrinsic pathway is a longer pathway. Okay, it takes longer than extrinsic pathway. So that was just the general idea of what the extrinsic and intrinsic pathway are and how they are activated. Now let's talk about a little more in a little more detail about the factors that are involved in the extrinsic and intrinsic pathway. So both the extrinsic and intrinsic pathways, they end in the activation of factor 10A, and from then on, from the factor 10, the common pathway kind of comes into play. It does involve factor 5, 2, factor 5, and then 2, and then factor 1, the fibrinogen factor 1. And the ultimate goal of the common pathway is the conversion of fibrinogen to fibrin monomers, and then they kind of they polymerize within seconds to form fibrin meshwork. And so let's first talk about the extrinsic pathway. So the extrinsic pathway, as we talked about, is activated by tissue factor when there is external trauma to the external to the vessel. and to the external tissue, and that the tissue factor will then activate factor 7 into factor 7a, activated factor 7, and then that will kind of activate the factor 10 to activated factor 10a, and from then on the ultimate goal, the result is fibrin. Then we have the intrinsic pathway, and we talked about the intrinsic pathway is activated by 7-methylcollagen. High molecular weight kallikrein is also an activator, and also the kallikrein. And when that is activated, it activates factor 12, and then factor 12 activates factor 11, and factor 11 activates factor 9, and the factor 10 is not involved here. It is involved in the common pathway. This is the ultimate result of both the pathways, is to convert factor 10 to factor 10a. And so now let's touch a little bit on the anticoagulants. So these blue area highlighted factors, these are the targets of warfarin. Okay, warfarin inhibits these blue the blue highlighted factors, and these include factor 2, 7, 9, and 10. These are procoagulants, okay, but there are a couple anticoagulant proteins that are also inactivated by warfarin. And what are those? Those are the protein C and S, protein C and protein S. So these are actually anticoagulants. And one of the reasons that's important to know is that when warfarin in a patient with protein C deficiency, if you give warfarin to patients with protein C deficiency, then it will result in knockout. Warfarin will result in knockout of protein C, and that would result in, as this is anticoagulant, that result in increased procoagulant activity, and that results in clot formation. And that complication is called warfarin skin necrosis. The skin is more prone, and that is the vessels there are kind of coagulated, and this results in warfarin skin necrosis. So, and why are other factors not inhibited? Not inhibited before protein C is because the protein C has the shortest half-life of these factors that are inhibited by warfarin. And so this is one of the reasons that heparin bridge is kind of used. So warfarin is not initiated alone, but it is given with heparin initially, because first it's the mechanism of action is really it takes time for its action, and also because the reason for that is because it inhibits the factors that are still in the blood function because it inhibits the formation of newer factors. So the factors that are still in the blood will function, and so this is why it's the action is really prolonged. And then when the new factors are kind of what is inhibited by warfarin, so it takes longer for the warfarin action. Then coming to the unfractionated heparin. So unfriction heparin inhibits these yellow highlighted factors, factor 10a and factor 2a. So these are inhibited by unfractionated heparin. Then there is also low molecular weight heparin. So the low molecular weight heparin, they mainly inhibit factor 10a, and they have a less inhibitory effect on factor 2a or thrombin. So the reason for that is because the unfractionated heparin is a longer molecule. It's a big molecule, and so it can fit the thrombin here. While the low molecular weight heparin, it has a low molecular weight and is a smaller, so it cannot fit. It cannot fit the factor 2 here, and so it has a really less effect on factor 2a. There is another kind of heparin related anticoagulant, and that is the fondaparinux. And it is a inhibitor of factor 10a. So and it is an indirect inhibitor. So the factor 10a inhibitors can be direct or indirect. Indirect is this. And then direct inhibitors include rivaroxaban, and apixaban. Don't worry, the names of these anticoagulants are harder to remember, but I'll try to make it easier. And I've also watched a video on how to make it easier to remember the anticoagulants. The link of that will be in the description below. So then, in order to kind of remember that these are direct inhibitors or inhibitors of factor 10A, is it has factor 10A in its name. So these two have 10A in its name, and these are inhibitors. And also it has it has X in the end. So this is how you kind of remember that it is a 10A inhibitor mainly. And these two are factor 10 inhibitors. And these are also oral agents. Remember, heparin is not oral. It's an injection form. It's a subcutaneous. So then coming to, so these were the factor 10A inhibitors. Now let's talk about thrombin, direct thrombin inhibitors, or factor 2 inhibitors. So these include argatroban, bivalirudin, and dabigatran. So now you will ask how to remember these, and it's pretty easy really. So it has the name bi. Okay, these two have the name bi, so it makes it really easy because bi means two, and these are inhibitors of factor 2. So dabigatran, or you can say bivalirudin or dabigatran. So these are they contain bi, which means two, which means factor 2 inhibitors. So this is how you can you can kind of can remember these. Another and the argatroban argatroban. The way to remember this as the inhibitor of thrombin is that you can just pronounce this as argatroban. So you just put from yourself an M here. So argatroban, and that will be that is how you're gonna make it easier for yourself to understand to kind of memorize these names and to remember them. So this was a quick discussion about the coagulation pathways, and hope it was helpful.